Thank you very much, Andy. I know this time spot is most likely the most challenging right after lunch, so I hope everybody is awake and alert for the session, correct? Yes. Excellent, excellent. So I have my distinguished panelists next to me here. We have Raphael Jafrizik, Group Transformation Director from BlackRock Health. We have Lynn Guthrie. She is the exec sponsor for Bonds Connect, Chief Strategy Officer of Bonds Health System. And we have Eric Neville, EHR Project Lead, CIO at Matter. And just a quick introduction to set the stage. I think this morning's sessions were fantastic. I know between Andy and Claire talking really set up a deeper dive into what we're talking about here, because each of our three panelists are really at different unique places along the EHR journey. So we're going to try to keep this interactive with a few questions from myself, and then hopefully if time allows, I'll ask for a question or two from the audience also, just to ensure you're paying attention. That being said, my areas of responsibility are really twofold. I have a team that helps with deployment through EHR Go Live, and then I also have a team responsible for ongoing support and education, and ultimately best practice utilization of the software, because as we all know, the journey does not end at Go Live. You know, and EHR really has to be fed and nurtured, and as healthcare changes very frequently, an EHR technology needs to keep up with that pace. So that being said, I want to dive right in. I'll sit back down so we'll keep this informal. And I'm going to start left to right with question number one. So, Raphael, just explain how your organization came to the decision and what goals might have been part of that decision based on your journey at Galway Clinic and now BlackRock.
Sure, yeah, and thank you very much. Well, I think we're in a bit of a kind of special place compared to maybe some of my colleagues, in the sense that within our group, we have a vast disparity between our level of digital maturity, especially in relation to EHR. So we have one side that already has a fully comprehensive EHR and highly digitized. We have another one that's on paper and another one that's kind of have half of an EHR. So really our goal was, you know, other than the really classic kind of patient safety benefit and clinical decision support, which I'm sure we're all going to hear about, was the fact of being able to standardize, you know, our processes, to be able to kind of give the same patient and the same clinician experience across our group, which is obviously very important, so that we can provide the best level of care to all involved by using, you know, the best technology possible. But also from a business point of view, being able to use standardized process, standardized metrics across our group, so we can actually compare, you know, likes for like, rather than having three, you know, sites on three different systems with three different type of metric that they calculate in different ways. So that was very important for us also as a group, you know, to some extent, you know, our EHR is our workhorse for data, you know, on top of, you know, all the patient benefit that you hear about. So that was our big goal, that standardization approach.
Excellent. Lynn?
Thanks very much. I suppose for us, when we were developing our 2025 strategy, really we realized it was fundamental to support our strategic goals for the organization. And I think from hearing from other speakers, and I think what everybody knows in the room, we have to do things differently in order to meet the demands of our patients, to be able to, I suppose, provide additional capacity and access for them. And I suppose this is an opportunity for us to be able to do that. And for us, you know, our strategic goals are around exceptional people delivering exceptional care. And for us, this is an enabler for that. We also have a new Limerick hospital coming on stream, a brand new hospital in Limerick, which is badly needed in terms of capacity in that region. And again, in terms of our planning, this was about having a system ready to go into a greenfield site there as well. Similar to what Raphael was saying, it's about standardization, looking at, I suppose, taking away silos of information, not only within a hospital, but across our hospitals. So we have 5 hospitals that we're bringing live onto the EHR platform, and with that brings lots of opportunity.
Great. Eric?
Similar. I mean, we have the exact same experience. You know, it's patient safety, improve efficiency for our staff. But you know, one of the big challenges we all know is paper. I mean, we have multiple locations, and you're trying to move charts between multiple locations. It's not safe, it's not cost effective, it's not timely for your patient. And one of the other big parts for us is the EHR is only part really of an overall digital journey we're doing. Obviously, one of the things we want to do is, I think we always compare ourselves to other hospitals, but we need to compare ourselves to other industries. And we're probably, there was actually, I was saying this to Gina yesterday, there was an article yesterday by the consultants and GPs of Ireland saying that we are 15 years behind other countries. And what's, I've come from other industries. When you join it, it's shocking that we're doing procedures and operations with robots, and then you're writing it in a paper chart, and we're still using paper. So the big part for me when I joined was, looking at the idea that we should, if I go on holidays, I can bring everything with me. Okay, I can bring my bank details, my passport details, everything I want on my device. If something happens to me in that country, I have no way to show somebody my history, my thing. So a big thing for us will actually purely be down to the patient. We want to make it they should be able to access us 24/7 and access their data 24/7 in an efficient way. So this is part of a project rather than the be all and end all. Now, it's a huge part of it. It's a huge undertaking, but that's all part of our journey. And very similar to the other guys, it's about efficiency, making it easy for our staff. And I think one of the things you've probably seen and we see is, there's medical people who move back to Ireland from other countries. They come into our hospitals and they're shocked. It's like as if they're going in a time warp back to paper, and we need to get away from that.
Yep. So some common themes we've heard about: an opportunity to standardize, an opportunity to digitize and take action on that data, not just internally within the organization, but also for the patients and communities we serve. And ultimately, I think striving and driving towards a paperless system or a more paperless system than where I am today. So great, thank you for that. Now we're going to reverse, and we're going to start with Eric on question number 2. Personally, I think the governance process, which is really representative of stakeholders that will be affected by the EHR, along with a adequate communication plan, is really one of the highest factors in success. So I want to talk a little bit about what that is at each of the organizations, and has it adapted along the way as the journey has progressed?
Yeah, I mean, we've multiple different governance groups. I mean, we start with our own EHR team, and that's a kind of regular mixture of clinical, administrative, finance, project management, and IT. That's kind of the more regular governance group. We've another layer above that then, which is into more the, I suppose say, the middle management layer, just so that they're aware of the project. They've full visibility within each department, and sometimes what you'll find is that something that might work really well for the admin team may not work so well for the clinical team, which may not work so well for the finance team. So we make sure that's a cross-functional governance team. They meet every month. Now, what we're finding is we're changing it to more every 2 weeks, every week, as we're getting closer to our go live. And then we have a core senior management team, which includes our CEO, CFO, COO. That's a monthly governance group as well, which I sit on as part of that as well, and I present to them. And then we're very lucky, our boards are heavily involved, so we have a monthly update with the board as well. So there's a board update from myself into the board every month as well. So that's to try and give the visibility, but it's a hugely cross-functional team in each area, to be honest, between clinical, administrative, finance, IT as well. So I would say we have a mix between the different governance groups. We probably have about 35 to 40 people in the different governance groups. Sorry, I should always include the bean counters. So finance, we have very much a finance governance group as well, just to make sure that, well, one, that I'm not spending more money than I should be spending, but two, is that it's in line with what they need at the end of it as well.
And do you feel along the way the right staff or people are empowered to make quick decisions when they're needed?
We've been very lucky, to be honest. I mean, thankfully, I have a lot of free reign. I'm the budget holder, but budget controller to sign off, so I don't have to go through a lot of. You can't. I mean, the timeline is tight. There's a lot of things that change, and we've had to change and adapt as we go along. Thankfully, I've got good sign off within the project. Obviously, every month it gets updated as well to make sure that it's been we're behaving. But yeah, we've a lot of freedom within our project.
Good, Lynn. Anything to add from the bonds perspective?
From our perspective, we're at a different stage, I suppose, in our journey. We're starting out, and really we've put a lot of thought into how we've formed our governance and structures. Really, I suppose, to make sure that we're agile enough. We've really put time in terms of how decisions can be made, our decision-making matrix, at which level within the governance, how can decisions be escalated if consensus can't be reached. and having the right people in the right working groups and steering committees. So we've put a lot of thought into that. We've also, I suppose, looked at how we can build in security and compliance by design as well as part of that structure. So we're hopeful we're setting ourselves up for success with regard to that governance structure. We've taken guidance from Nordic experts in terms of setting this up in terms of other projects, and also learning from our colleagues here as well who are further along in their journey.
Great. Now, Raphael, I know you're in a unique position with Galway Clinic already live with a deployed EHR. Are there any types of lessons learned that you're incorporating as you look to the future as BlackRock as a larger entity, knowing some of those challenges of going from paper or anything else?
Well, we are, but we're finding different kind of challenges from a governance point of view. Now, actually rolling it out to a group level. And by far, governance is what we identified as the most challenging aspect of this program. And other than making sure that we have the right people at the table, that's a given, you know. But what's actually extremely challenging is that fine balance of one, having a very robust governance infrastructure, but also an efficient one. And sometimes the two don't go really well in hand. Just to prove a specific point, a delay of 1 month on the program will cost over 200K for us. So a decision being delayed by a month, 2 weeks, even 1 week, will have a direct financial impact on our program. So what we're trying to do is to make sure that we have very specific level of authority to different people within the organization, but giving as much authority level in the service area. And then after, hire for senior management, and then hire at a group level. Now, not everybody can make any decision. You know, there's clearly, and my colleague, I'm sure, have the exact same experience, some decisions are extremely strategic and can be only made at the top table. But we want those decisions to be, you know, the 1-2% of all our decisions. And that most of our decisions will be made, you know, at the service level. But that being said, for us, and I don't know if it's the same experience for my colleague, but coming up as a group rather than a site is a completely different ballgame. You know, everybody's seeing that they're doing their discharge assessment the best way possible. And you'd think that they all do them the same way, but they don't. And sometimes it's just a small modification that actually have a massive impact. But when you're thinking as a group, you need to then agree on a standardized process. And same thing for your admission process, same thing for your discharge, same thing for your billing, for every single thing like that. And to be fair, being set up as a group but with independent site is not the same thing at all as from now on, everybody's going to do their admission the same way. Everybody's going to be doing their discharge the same way. And there's no really governance structure that exists, not even at an IT level, because it's not IT whatsoever, it's business level. There's no governance that exists for us at that level. So really, this program is actually creating all those type of governance level, that's why for us we found that it is so tricky, and it's beyond just having the right people making the right decision. Is okay, who makes the decision now?
Yep. Great. Now, before I move on to the next set of questions from the audience, any questions specific to the panelists around governance, communication that you'd like to ask? Anyone? It's always tough taking that first step. Okay. If not, I'm going to ask a couple of unique questions now, since the panelists are at different areas of their journey. So, Eric, I'm going to start with you. So tell us everything and anything you'd like to share on how you approached user acceptance testing and end-user training, please.
Okay, nice easy one. So like, UAT, I suppose, is structured. I suppose that you kind of have a program. So we've worked generally through initially a prototyping type of structure, which was very much done with the existing internal team. So just to give you an idea, within our project team overall, we would have hijacked about 30 people out of the hospital, you know, from nursing, lab, pharmacy, admin, a mix. We have a good cross-functional mix. So in the first, build, we do some very basic prototyping of, registering a patient, booking appointments. we add on the modules, give them a lab, give them a CT, give them, and the whole way through to billing as well. So that was the first round of prototyping, predominantly done within our own team, okay? Then we've started moving into, back around December time, we went into UAT1, and that's where we had to hijack staff out of the hospital to bring them in. So we probably engaged about another 50 staff from within the hospital over a 3-week period, each testing each of the modules, individual lab, pharmacy, and like that as well. So that's been a fairly, I suppose, interesting kind of journey, because you have the UAT where you're trying to get them to test, but you're also trying to show them the system, because it's the first time they've seen the system as well. So there's a lot of feedback. A lot of it nearly turned into actually nearly an initial training than a UAT, and there was lessons learned from that probably, is that it wasn't in depth enough of a UAT we're doing. Whereas now we're into UAT2, which has about 150 people involved across the hospital at different phases. And we've got scripts, we've taken the top procedures and the top challenges, and we're trying to run through them at the moment as well. So we're actually live in the middle of that as we speak now at the moment. So it's a big group, and it's actually trying to gather that feedback. And one of the challenges we found is we probably haven't left enough of a gap between UAT1 and going to UAT2, because out of UAT1 you find things that quite simply people, it didn't work, or it's not going to work for them. So it's a timing thing. So what I would say around UAT is you need plenty of people involved. It needs to be cross-functional, but you need plenty of time between the different phases as well.
Yep.
Training is probably the biggest one, and we've talked about this. I think we all talk about this. Is you're getting to a point where you're going to have to try and train 2,000 staff. Now, for us, the biggest challenge area is going to be around nursing, because we quite simply, we're very paper-based. And obviously here it's different, you've got the EHR, but because we're paper-based, we need to try and... So for training is huge. I mean, we have to try and, it's very busy. I mean, I'm sure all the hospitals at the moment are very busy. And then I'm going to everybody saying, that's lovely, and I now need to take nursing out of work for 2 to 3 days. So what we're doing is we're doing a combination of classroom-based training, and we reckon for nursing, which is our biggest cohort, there'll be 2 days initially, and then a 3rd day probably as well. But what we have done as well is we've rolled out an online learning system, LMS, which we've done over the last few months to get people used to using this. And we've hired in a content creator, so we're doing a lot of video content as well, because if you think about it, we're starting training in 19th of March. We're starting with our first cohort of nursing. We won't go live until the summer. So there's a big gap between when they've had their training and when they go live. So we've got a lot of video content that they can then use as refreshers as well. I would say it's probably the biggest challenge. Because also you've got independent consultants, the secretaries of independent consultants, and every single person is going to touch this system going forward. So, and then you get into that lovely question about where do you do it? So it's locations. We're in a fairly tight area where we are based. You have a lovely plush building, so you're slightly different. But where we are, we're fairly restricted. So, believe it or not, I've been hijacking a disused laundrette, disused pub, a basement area to try and find locations and devices for training. So, do not underestimate what you have to do around training, to be honest with you. And then you're going to have this whole big hand-holding exercise you have to do after go live as well. And then refreshers. And one of the other big challenges, we've talked about this before, is what do you do about agency staff who need to come in. And that's probably why we have done a lot around our video content as well, whereas we'll try and make it mandatory that any agency staff coming in will have to do the online training at least before they come in.
So 2 quick follow-up questions.
Make them easy.
Depending on role, is there a minimum number of hours training, and is it mandatory, which I'm assuming?
We're making a rule.
Okay.
If you're not trained, you can't go in the system.
Okay.
Which will be the most challenging? Probably the consultants. Right?
Understood.
So you're trying to get consultant time. So again, that's why we want That's why we want to have as much video content for them, so they can do it whenever they want and wherever they want. And then you're up to some cases where it's up to 3 days of training for certain areas.
Okay. Great.
And I think one of the biggest challenges is going to be is that a lot of our nursing staff, they don't use a device day in, day out. So it's getting, because we're going to be using handheld devices and things like that as well. So it's getting them used to even using the technology left of the system. That's the nice journey we have now from the middle of March.
Great. Thank you.
Okay.
Lynn, we're going to change subjects a little. So I know we've talked over the last few months about the possible opportunities that digitizing data the system will be able to leverage, whether it's for patients, other care providers, or outside agencies. So do you just have any thoughts on what those opportunities might be out of the gate or down the road as more data is digitized and becomes paperless?
Yeah, I think, it's about doing things differently, isn't it? So as, has been said earlier, we're part of an ecosystem here. So whilst we might be a health system or a hospital, patients will use multiple points of care. So I think Dr. Power summed up with a nice example there around silos of information, and that's not really the full picture for a holistic view in terms of patient care. So really, I think we all have a responsibility as well as an opportunity, I suppose, to make sure that we're now, as more systems and hospitals are coming onto an EHR, and I know with Meditech as well, there's opportunity with regard to the Meditech Users Network and looking at how we're talking to other providers within the system, whether that be GPs and community, and obviously we need to grow that, whether it be public hospitals, because no more than the other hospitals here, I mean, Bonds Core Health System does a lot of work for the HSE and public patients. So it's not so much about having a public patient or a private patient, it's about a patient within the overall health system. And I think we need to be able to leverage the EHR to be able to break down those silos of information, not only within our own organization, but out there in the wider community.
Yeah, no, I think that's an excellent point, and I think Tomas brought that up earlier, that the data really resides with that patient, whether they're under our organization's care or receiving another organization's care in the community. So that excellent point. Raphael, so let's talk more about, I guess, Galway Clinic's experience, since they are live with the EHR. Once you deployed it and hopefully went through some optimization, is there a success story or two you could share with us in retrospect on whether it was a planned success story or one of those, wow, look at this added benefit we got just from digitizing and moving in that direction?
Yeah, and I think, obviously there's loads of absolutely obvious one, but one thing that's funny, and we often kind of have that kind of wake-up moment, is you go back to one of our sites that is paper-based, and you realize, oh, yeah, it's not like that anymore. Specific example, very easy one, electronic prescribing and administration. That's one of the most obvious one, Obviously, by default, you'll get allergy interaction, you'll get drug-to-drug interaction warning, you'll get, lab value warnings depending on what drug you're prescribing. If you compare that to a paper system, there is no amount of communication, no amount of training that can just equal the level of safety that you get from e-prescribing. At the end of the day, we are all human. At some stage, we're going to have an extremely busy day. We're going to be under a huge amount of stress, and then we're going to forget about something. Or we're going to forget about one of our policy, or we're going to rush through a process. And it's because we're human. Education, policies, guideline is not going to save you from that mistake. That might be once in a million, but that could have an absolutely terrific impact on a patient. While with those systems, there's no way to avoid them. Like we can see very specifically, every time one of our prescribers gets a warning about the fact that there is a drug interaction on the order they're trying to put in, and we can see precisely every time they're changing that because of that warning. So we know those systems, we know for a fact, it's not just kind of, all rosy and hopeful thinking. We know for a fact those systems have a direct impact on patient care, on patient safety, on safe prescription, et cetera, et cetera. And that's an obvious one. One of the other one that I think also is always very simple is audits. How many of us have to do audits? And how often do we have to do audits? And no matter any hundreds of people you throw at audits on any type of guideline that you might have, you're still always going to audit a sample of chart. Well, I'm sorry, you have an EHR, no, you actually audit every single chart possible. Example for us, we audit what is the exact timing between a prescription of an antibiotics until the administration of that antibiotics. Try to do that on paper. You're never going to get the exact number, while here we're able to have informed decision-making at the moment it's happening, And, you can only do that with an EHR. There's no other way. And as I say, it's as soon as you've gone through that step, you realize, oh, what were we doing before? But it's what Eric was saying, like we are 15 years behind. There is not a doubt in the world when you look at other countries. But it's great to see at least so much movement over the last 2 years. That's fantastic. And one thing I say all the time is that there is not one hospital that go and implement an EHR and go and say, we made a mistake. It's going to be challenging, it's going to be difficult, there's going to be engagement of patient needed, but there is absolutely nobody that 6 months later is going to be like, oh, we should go back on paper.
Yeah, exactly. Now, thank you for sharing. And before we get to that next question, because I think it tees it up quite nice, I think you're starting to brush at, just the power of once going live in harnessing that data to make better decisions for your staff, for the patients, because everything is literally right at your fingertips now, and it's a massive information that you can start making better decisions on. So that's wonderful. So last formal question, and then if we have time, I just wanted something to provoke some conversation at the next break. Any specific lessons learned or aha moments along the way that you think the audience would like to hear? I'll just, if anybody has it, that's fine. If not, okay.
I have an easy one. Add more time. Don't underestimate the size of it. It's huge.
Okay.
Yeah. One of the big things for us, on top of the benefits of going to it, is, you have to take the amount of systems involved in a hospital. Okay. It's huge. And we're folding a lot of them into one provider. And one of the challenges I have seen in the past is because you have so many systems, it's very hard to then get upgrades done because you're dependent on so many people. But we're folding about 30 different systems across the hospital in one go. So that's a huge thing for us as well. So just don't underestimate the time. And look, you have to remember our timing was a little bit off because COVID was in the middle of it. So, you've got to cater for the unexpected.
Yeah, absolutely. Anyone else have any aha or lessons?
Happy to jump in. Well, obviously, in relation to time, I'll give 3 of them. One, don't underestimate the time it takes to hire people, especially if you do that internally, which at some stage, no matter which route you go, being consultancy or internal knowledge, you're going to have to hire subject matter expert. And as Eric pointed to earlier on, that means that you're taking some of your nurses or some of your managers or some of actually the most valuable people, sometimes the people who know the most about your process, you're taking them out and say, I want that. I'm well known in my organization because they always hate me because I take the best people out of their team, so they blame me for it, but then they get them back. But so that's one, and it takes a long time. If you want quality people, it's going to take a long time to hire. Interfacing is tricky. You're always still going to have, it's not because you have an EHR that you're not going to have any third-party system. You will, and the integration is highly complex. But for me, maybe the biggest one is people underestimate sometimes what an EHR is, and sometimes, it's just a clinical system, or it just do that. And, well, we could actually put that really nice and shiny system just on top of it, and it can do that slightly better. And that is the worst thing you could do. You're literally ripping your EHR apart. And it took us many years to get to that lesson, as to be very careful as to, which system you want to replace, even what you think is a very small portion of your EHR, because the data is so integrated that the moment you start removing one area of it, let's say, for example, I'll take a very quick example, I don't want to take too much time, but materials management. You might think materials management and ordering and stock control has nothing to do with your HR. Well, wrong, because that's everything that your drug formulary is based on, meaning that the way you administer drug, when they're administered, when they're depleted from your stock, is actually highly integrated with your clinical system. And you might think, actually, I don't really like the materials management system of Meditech. Let's put another one that does that really well. And then you've ripped out a massive portion of your HR. So that would be my biggest learning point over the years, as to sometimes it might not do everything as well as you like, but the integration of data that you have behind it at an organization level surpass everything that will be worth putting another third party instead of that.
Great. I really appreciate that. I know time is up, so I will simply leave this for any type of conversation, because I'd personally like to hear the feedback throughout the day if anybody has ideas. But over the last few years, AI was such a popular hot topic, but it was always, what's the use case in healthcare? And at least from our organization, fast forward to today, we're ready to release some AI-driven functionality that helps in discharge planning in just a few short years. So I challenge everyone to think about, as they're looking at their 2 to 5 to 10-year strategy, Are there holes out there that you think an EHR vendor might be able to help you fill and complement the care you're doing? So I'll simply leave you with that. I want to thank my panelists. I thought that was excellent. I appreciate everybody's time and attention during this. Thank you very much.